Chicago's Children and Adolescents Hospital, where, as Florence Nightingale once said, "For the sick, it is important to have the best." Our vision here as nurses is clear, as it is our function to be knowledgeable and skillful, but to also provide compassion to our patients. We also provide excellent care and pave the way to improve the health of people we serve and guide the recovery of the ill in a therapeutic environment. Our mission statement is as is, to build a legacy of compassionate and quality care for our society through evidence-based practice, positive attitude, and professionalism. We will maintain a high standard of ethics, integrity, and respect and value of our patients while meeting their holistic needs, physically, spiritually, mentally, and emotionally. Last but not least, provide preventative, diagnostic, curative, and rehabilitation care with the utilization of advancing technology in order to enhance care of our patients. I now invite you to sit in one of our post-clinical conferences where we will explore the role of our nurses, see how they interact with each other, and evaluate themselves. Let's go!
Welcome to our first weekly post-clinical conference for the month of March. Thank you all for coming. For the students who it's your first time being in our post-clinical conference, I have a bit of history about our institution for you. Our beloved institution, Seattle's Hospital for Children, was established in 1848, and we are the only children's hospital in the Caribbean. We care to the children between the ages of 0 to 18 years. We consist of 50 wards, outpatient departments, inpatient service department, medical department, nursing department, dietary department, housekeeping department, just to name a few. We also collect for a staff complement of 500 workers. Before we get into the meat of the matter, here are a few words of encouragement for you, my lovely colleagues. Life is not easy for any of us. But what of that? We must have perseverance and, above all, confidence in ourselves. We must believe that we are gifted for something and that this something, at whatever cost, must be attained. Marie Curie. Our end of shift report. We started the shift with 20 patients. There are 2 category 4 patients, 8 category 3 patients, and 10 category 2 patients. We had 4 scheduled surgeries today. 2 of our patients are currently at the operating theater, and 2 are still waiting to go to the operating theater. We had 2 discharges and 2 admissions. A 5-year-old girl with a bowel obstruction, which was caused by animal fur, and she's a category 3. And a 10-year-old boy with an open fracture to the femur, he is a category 2. We currently have 18 patients on the unit and 2 are still at OT. Let's get an update of the plan of care for Jessica.
Assessment data, objective data, dressing to midline, diagnosis, impaired tissue integrity related to surgical incision, secondary to abdominal laparoscopy as evidenced by dressing to abdomen. After 8 hours of nursing and collaborative intervention, patient will show signs of wound healing as evidenced by granulation tissue formation, that is the goal. Interventions, dress wound as ordered, avoid sticky and tight dressing. Rational, continuous dressing. Second intervention, administer medication as ordered. Antibiotics will promote bacterial growth and promote wound healing. Evaluation, goal magnets.
Nurse Campbell. Yes, care plans, very sparse, my dear.
Sister, we just never have any time. On Fridays, there's only 5 of us working, and there's so much patients on the ward. It's the best I could do.
I understand, but remember the quote that I stated for us earlier on, that no matter what the cost, our goal must be attained. So I understand that yes, you're very busy and very tired and a lot of things going on the ward, but still the patient comes first, and no matter what the cost, we have to ensure that proper patient care is done. When I think apart this care plan, what this is saying to me, even your very assessment was not thorough. The assessment was not thorough. The only thing we have there about the assessment of the patient is that they have a dressing to the abdomen, and it's saying that they have tissue integrity. Because there is a dressing, there is impaired skin integrity. What happened? What caused the impaired skin integrity? What really happened? A laparoscopy. What really happened during the laparoscopy? Was it not disruption or cutting of the patient's skin? Cutting of the patient's skin that caused the patient to have impaired skin integrity. We didn't even do an assessment of the patient's vitals. No vital sign information. You have your intervention that you are administering antibiotics. What antibiotics are you administering? I understand and really do understand the plan. I'm going to take into consideration that the staffing for Fridays is not adequate, and I will meet with the departmental heads to discuss proper staffing for Fridays specifically, as what their policy is here is that we are supposed to have most workers off on a Friday. And I realize that yes, it is affecting me, and now it's affecting our patient because we really have no information to go on for the patient, no assessment, we give the patient antibiotics. We don't even have a temperature to tell if the patient is having an infection or anything like that. You understand what I'm saying? I'm not throwing on the bus because I have confidence in you, and I know you have confidence in yourself, and I know that personally, you know that this is not your best work. But another time, I am expecting that in the future, we will not be here. These things will be corrected. Any more information on the other patients?
So the second patient, Bernd Brown, 10 years old, medical diagnosis, compound femoral shaft fracture. So based on the client, based on the assessment, our nursing diagnosis was acute pain related to stimulation of pain receptors secondary to compound femoral fracture, as evidenced by verbalization of pain rated 8 out of 10 on the pain scale to the right leg, facial grimacing and guarding of the right leg.
Wow. That is a thorough assessment. I can see that as a nurse, you went in and you did your thing. That is just so beautiful. And I want for every one of us here as nurses to follow in our Nurse Francis's footsteps. Continue, Nurse Francis.
Okay, so our goal for this patient, after 30 minutes of nursing and collaborative intervention, the client will experience a satisfaction in pain relief measures as evidenced by patient rating a reduction in pain of no greater than 3 on the pain scale. Interventions. Our first intervention is to establish a therapeutic relationship with the client to promote ease of communication. Our second intervention is to teach the client diversional therapy such as deep breathing exercises to distract the client from the pain. The third intervention is to reduce movement, which is a factor that increases pain. Our fourth intervention is to medicate the client with a prescribed analgesics. In this case, it was pethidine 1 milligrams IM every 4 hours. Our evaluation, the goal was met after 30 minutes of nursing and collaborative intervention. The client experienced a reduction in pain as evidenced by patient rating the pain 2 out of 10 on the pain scale.
Wow. It is obvious that you performed optimal patient care and optimal nursing care because the interventions that you did for your patient you can see that the goal was met at the end based on the intervention that was done. And I have a quote for that. Save one life, you're a hero, but save 100 lives, you're a nurse. And indeed, you are all nurses. This time we will hear what we have so far on our 24-hour report.
Jessica Thomas, a 5-year-old, registration number 110295. She's on bed 8, diagnosed with small bowel obstruction post-op. So she's a patient of Dr. Dallas. He did a post-abdominal laparoscopy under general anesthesia. Surgery was uneventful, minimal blood loss, normal blood pressure readings throughout the surgery, normal saline and lactators removals for the fluid replacement, received patient drowsy but presently in a stable condition, medicated as ordered, dressing intact, same clean and dry. Patient took tea and biscuits, then soup for lunch, same tolerated. Normal vital signs, temperature 35.6 degrees Celsius, pulse 65 BPM, respiratory rate 16 BPM, blood pressure 93/65, SpO2 98%. We also had 2 discharged, 2 post-op. We have Rory Bryan and Joanna Wayne. Discharged, their take-home medications received, patients educated about care while at home, and their follow-up dates were given.
All right, thank you, nurse. We will now go into our audit. We have the audit report.
Okay, sister. So for the admission process, there needs to be more detailed information and the assessment of the client's condition. So, example, the focus assessment, there needs to be more detailed. For the admission entry, I'm not seeing a thorough nursing plan of care for the patients. Generally speaking, the forms used for the patients, example, the fluid balance charts, they are not up to date. Like, they're there, but there's no information on it. For the medication, I'm seeing where medication is being served and the medication order is not completed. So I don't know how that works. Preoperatively, it was a good job with completing the preoperative checklist, clients being educated, consent from signer, witness, and assessment completed there. With discharge, I think there needs to be more information on the assessment of the client's condition before leaving the unit.
Okay, thank you. My fellow colleagues, as I've said on multiple occasions, that we need to believe in ourselves. We need to be confident in our abilities to carry out our work. I know that these are strenuous circumstances. I know that we are experiencing a lot of pressure, but that still doesn't mean that we should neglect our work or be half-handed in how we do things. I would like to hear from you guys, what are some of the issues you are having? Why we are having, for admissions, we're not having detailed assessments being carried out on admission and detailed assessments being carried out for our patients when they are discharged.
Well, like it's the same thing as I said earlier, sister.
Words and
other
staff.
staff.
Yes.
The time is just not there.
True.
Okay, I understand, but we have to believe in our abilities and we have to have faith in our abilities and we have to be confident enough to do the things we need to do regardless of the circumstances we're having. I am going to speak with the departmental heads, as I stated earlier, and see how I can sort out the staffing issues we're having for Fridays.
Okay, sister, so going through our patient satisfaction surveys, I realize that we have 3 prominent issues, right? Where quality of orientation to the ward is 1, the meal service is 1, and maintenance of privacy is also 1.
Alright. Ladies, put a smile on your face. Be not disheartened. I know these issues cause you guys to feel downtrodden, but I know that you are competent nurses, and I trust and I have faith in all your skills and all your abilities. For the quality of orientation, I can understand with our patients wanting proper orientation, because remember, proper orientation promotes patient safety on the ward, and we are catering to kids, children. So we have to properly orientate them so that it can lessen their level of separation anxiety from their patients, allow them to feel at home, right? And maintenance of privacy. We know that the wards are very hectic with multiple persons on the ward, so we really and truly need to work on maintaining the privacy of the patient. So when we're doing procedures, we have screens at the back of the ward, so go for a screen and create a private environment for your patient to carry out your different procedures. And for the meal preference, what we can do is speak to the parents more and find out the things that the children prefer, and on those given days we speak this based on what is being offered at the dietary department. We give the children those meals on a daily basis.
Sister, you know that you're a very charismatic leader.
Really? Tell me more about it.
Alright, so the definition of a charismatic leader is that it's a trait-based leadership, where the leaders act as visionary. They are usually driven by their convictions and motivate their followers to work towards common goals, common visions, using their charm and persuasiveness. So you see how you're always encouraging us with a little quotes. I find that very charismatic.
Oh, okay.
These charismatic leaders, they normally act as role models, and they exhibit extraordinary characteristics that inspire devotion and motivation in followers to pursue change. So just like we were telling, the nurse just know about the care plan, but you were very charming in how you executed it.
Okay.
They use these gifts to maintain power and control over the group in a good way.
Okay. I think I possess all of those qualities.
And you do sister.
On a daily basis, I try to encourage all of you colleagues to work hard and to believe in yourselves.
You do.
Alright, so those are the advantages, but with everything you have disadvantages.
That's true.
So let me tell you some of the disadvantages of being a charismatic leader. So charismatic leaders with a less self-assured foundation can prioritize their own focus instead of that of the company or our organization. Also, a disadvantage is charismatic leaders may create the illusion that nobody can replace them, which can create issues for a company that needs to replace the leader. Lastly, it is dependent on the energy level of the leader. Therefore, if the energy level of the leader sinks, or others may become demotivated and less willing to follow or complete their task.
Thanks, Nurse Francis, for all of that, and thank you to everyone who attended our conference. Have a good rest of the day. Nurse Newland wasn't even at the post-clinical conference. I wonder why. And look at her evaluation too. It's not up to par. I really need to have a word with her.
Good morning, Nurse Newland.
Good morning, sister. How are you?
I'm fine, thank you. And how are you doing?
I'm alright.
Alright. So, do you know why I called you in here today?
I know we're doing some evaluation business.
Alright, so I'm here to discuss with you your peer evaluation as well as your self-evaluation. So the self-evaluation was carried out by you. So it was basically you looking at yourself and evaluating your abilities and your performance. And your peer evaluation is your colleagues evaluating your performance based on what they see you do. That's what they are. That is what the peer evaluation is about.
Okay.
Alright, so let us get into it. Because I noticed a few discrepancies, right? So I noticed that on your self-evaluation form, you stated that I've seen where you have evaluated yourself to be performing within a very good standard to an excellent standard.
Right.
Which in it is your evaluation, so I cannot say that you're wrong, right? Because that's how you perceive yourself and perceive your performance.
Right,
What I'm
sister.
seeing here now on your peer evaluation form, I'm seeing quite a few discrepancies. So it's obvious to me, what this says to me, that your colleagues are having an issue with you.
It's probably some small stuff, sister. I don't think it's that serious.
Okay, all right. So I'm seeing here under the category of nursing assessment, I'm seeing where your colleagues gave you a 3, which is average performance. Average performance, and you know, and I know that average performance when it comes on the nursing assessment is not ideal patient care, because remember that we have to do thorough and outstanding assessment of our patients in order to care for our patients. Remember,
So sister, which nurse said that?
I cannot disclose that information because that information is confidential.
I need to know who said that, sister.
Alright, so I cannot disclose that information because it is these peer review forms are very confidential. But what they are saying on this peer review form is that at nursing assessment they gave you a 3, which is an average performance of your nursing assessment. You and I both know that as nurses, it is critical for us to perform definitive and thorough nursing assessment in order to promote and to carry out proper patient care, right? So I know that the day is hectic for you guys, and sometimes you just do the bare minimum. But you have to believe in yourself and you have to have faith in your abilities to carry out your work and to manage your workload. Because at the end of the day, you're not doing it for your for yourself, you're doing it for your patients.
Well, sister, I always take care of my patients. I don't know who write that about average nursing assessment. I don't know about that, sister.
Alright. Well, just be on your P's and your Q's, or just keep it in mind that your colleagues are having this issue, so you can try to improve patient education. They're saying that you're not educating your patients fully.
No, sister, I need to know which nurse filled out that peer evaluation. You need to get somebody else to do it. That one is not right.
Okay. Well, I will not tell you who filled out the peer evaluation form. But at the end of the day, do not take these as offenses. Just take them as criticisms, and these criticisms that can help you to become a better nurse.
Alright, sister.
Remember that you're in the life-saving business. So if you save one life, you're a hero. But you save 100 lives, you're a nurse, and that is what you are.
Alright, sister.
So do not be downhearted and do not feel like you're not doing your best. You are doing your best, but there comes a time when we just have to put in more than our best, right?
Right.
Alright. One other major infraction that I've seen with your colleagues speak about is your punctuality. They're saying that yes, you do come to work. However, when you come to work, you're not punctual. The shift starts at 7 and you're coming to work 7:30 and you're not calling to inform anybody that you're coming to work at 7:30.
Well, sister, honestly, you know I have a son.
Yes,
right?
I do.
A little boy, and he goes to preschool. And sometimes in the morning, like you're rushing and like the time catch up on you. So that's the only reason why I'm late sometimes. And it's not all the time, sister.
I can understand, but at the end of the day, remember that as a nurse, 1 second can determine life and death for your patient. And remember that with the patient load that we are carrying on our ward, we need all staff to be present at 7 o'clock.
Okay, I'll work on it, sister, definitely.
All right.
Mm-hmm.